And today my topic is pitfalls in management of urinary tract infection. And before discussing the pitfalls, and probably a lot of medical students, junior doctors, and before discussing the pitfalls in management of the urinary tract infection, I give them a brief introduction about the urinary tract infection. It's all you have already aware. But the urinary tract infection is the most common bacterial infection in here as well. So it's everywhere. So maybe in the outpatient department, maybe GP level, maybe come to the medical wards, surgical ward, gyn and obs wards, everywhere the urinary tract infections are there. And unfortunately, the worldwide, if you see the urinary tract infection, they sort of the guideline base, or maybe the clinical care pathways are available. At the moment in our country, for the management of the urinary tract infection, the critical care path is not available. So among us, probably when you manage urinary tract infection, there are no much of the uniformity. There are different set of surgical team probably manage urinary tract infection in the different ways, medical in some other ways. So clearly our urinary tract infections we are not managed in the bit of the evidence-based manner. So the urinary tract infection, if you see, it's a leading cause of probably the mortality and the morbidity. It's a world number one cause for the septicemia and the septic shock. The severe urinary tract infection end up with the septicemia and the septic shock. And in fact, Sri Lanka, it is a number one cause for a septicemia and the septic shock. If you don't treat, some of the patients end up with renal abscesses, perirenal abscesses, and some of the patients may end up with acute kidney injury. Elderly patient, very common, they present in the electrolyte imbalance. And some of the patients, they not treat adequately, end up with the chronic pyelonephritis, which is the third leading cause for the chronic renal failure. So in order to prevent all this acute complication and the chronic complication, it needs a bit of a high degree of awareness, and we have to treat the condition appropriately. Currently, probably as I said earlier, since we are not adhering to the guideline-based management of the protocol, it's like a Sri Lankan cricket. So we are good batsmen, good bowlers. So, but problem with no much of the commitment, no game plan, and sometimes maybe when you are batsman, the wrong probably maybe with maybe powerful shots for the wrong ball. So that's why most of the time team, they are sometimes successful, but most of the time not that so. When you come to the urinary tract infection also, we have not bit of a coordinated team effort. We treat individually urinary tract infection in various places. So as a result, we have not get the maximum benefit to the patient. So the urinary tract infection is an infection of any part of the urinary tract. It may be urethritis, which may be complicated with the prostatitis, maybe a bit of the orchitis, epididymoorchitis, then cystitis, pyelonephritis, depend on these anatomical locations. And we can divide some of the urinary tract infections are complicated urinary tract infection. Some of the urinary tract infections are uncomplicated. So again, when you try the simple thing, we diagnose the urinary tract infection depending on the history, examination, basic investigation. And most of the urinary tract in the female, we call it uncomplicated urinary tract infection. All the female, they are above 16 and 65 age. When they present in the dysuria, when they present in the nocturia, cloudy urine, if there are two or more of these symptoms, it's uncomplicated urosepsis, having excluded some other gynecological things. So in the NICE guideline and the UK, most of the guidelines based on these two symptoms, having excluded others, even without any urine analysis, or maybe after without doing any urine culture, we can treat for the uncomplicated urinary tract infection. So when a patient with a bit of uncomplicated urinary tract infection, mainly the cystitis or urethritis, they present with the dysuria, nocturia, cloudy urine, and some of the patients, they can have the urgency and increased frequency and the visible hematuria or suprapubic pain or tenderness. So if the patient had the previous two, this thing, so probably the two of these things are there, even no need to do any urine district, no urine culture. We can treat the patient for the uncomplicated urinary tract infection. And if the only one is there, probably we need the dipstick. So in the urine dipstick, if they're a bit of a significant, probably again without urine culture, we can start the treatment for the uncomplicated urinary tract infection. So when you see the patient with the dysuria, nocturia, and the maybe cloudy urine, the things is we have to exclude whether any patient with any vaginal discharge. If the patient has vaginal discharge, 80% of the time, it's not UTI. Or most of the patient may be dysuria. You have to get the history of a sexual history just after maybe the post-intercostal. Sometimes they can have the burning sensation due to the, and maybe due to the irritants. Also the careful history when they present with the to exclude sexually transmitted disease. And especially in the elderly, postmenopausal women, they can have all these symptoms to the, maybe due to the atopic vulvovaginitis. So having excluded all these things, if the patient has symptoms for the uncomplicated urinary tract infection symptoms alone, we can treat. That's the most of the, even the UK and the NHS, American specific area, most of the guidelines, even without much investigation, you can initiate treatment for the uncomplicated urinary tract infection. But all the patient with the complicated urosepsis, we need the urine culture, especially when the patient was in the high-grade fever with the chill centrigo, temperature more than 37.9, or the temperature is low. If the fever is less than 36, or patient present in the examination with a low in pain, low in tenderness, and when the patient present in the nausea, vomiting, always we have to suspect the possibility of a pyelonephritis. Especially, we are not forgetting that they include the some of the patient present the new onset of a myalgia like a flu-like illness. Most of the time we forget, we attribute it to the viral fever. But maybe the patient comes with the new onset of like a flu-like symptom and the myalgia, along with the nausea, vomiting could be a bit of a pyelonephritis. We have to take it very seriously. And very common other thing is a patient, when we had most of the patient, elderly patient, they are in the catheter. When they come in with a bit of a catheter-related urinary tract infection, most of the patient, we are a bit worried when they are on the catheter, their urine is a bit cloudy. It is not due to the urinary tract infection. Most of the time, when there is a catheter, it can cause the catheter-related bacteremia. And most of the color, you not only the bacteria, with the bacteria colonization, it produces probably the biofilms. So we can see the cloudy urine in the urine bag. It doesn't mean there's evidence of urinary tract infection. It is a sort of a bacteremia. But very important, along with this cloudy urine, you have to see the symptoms, whether the patient has true urinary tract infection. So the patient present with the fever, and the patient with the suprapubic pain and the tenderness, and the other, even after removing the catheter, if the patient has the urgency and all the symptoms, then we have to think of it as a catheter-related urinary tract infection. Then any patient coming with the urinary tract infection, especially the pyelonephritis, or maybe the catheter-related pyelonephritis, always assess the severity. You can see the news to this is the National Early Warning Score 2. That's the most you can apply for everything. It may be due to the pneumonia, it may be to the urosepsis. This calculated at the emergency department. So simple thing they are considering respiratory rate, saturation, blood pressure, pulse rate, level of consciousness, temperature, and some of the patient with that may be the oxygen supplementation. So for the level of conscious, pulse rate, and the heart rate, they are giving the 3 score, depending on this thing. Other one, the other one. If the patient is in oxygen, they give the additional, probably the 2 marks. So out of 14, they calculate your news 2. So depending on the news 2 is more than 4, it's a bit of a serious. More than 5, probably that with the more than 7, probably patient should be managed in a HDU. So if the patient is, especially if the patient is alone with this urinary tract infection, if they are still the pyelonephritis or evidence of sepsis, that is a tool we are using. The various tool we can apply for in the emergency department. Now the most of the emergency department, they recommend the news 2 calculator. So most of to diagnose urinary tract infection is a gold standard test is the urine culture and the ABST, but I said uncomplicated urinary tract infection, no need your urine culture or the antibiotic sensitive pattern. Without urine culture, you can initiate treatment, but complicated urinary tract infection, catheter-related urinary infection, always you need the urine culture before start antibiotic. Usually when the culture becomes to be positive, if there's more than 10 to the power of colony count in the culture, the most common organisms are the E. coli, maybe Klebsiella, maybe Proteus, Pseudomonas, Enterococcus, and all these things are causing for this urinary tract infection. But sometimes when the patient in the catheter, after removing the catheter, there may be two organisms. Still, in the blood culture is positive for two organisms, still we have to consider it's a possibility of a positive culture. But when the two organisms are positive, one organism should be more than 10 to the power of 5. Then the culture is positive. So when the patient is the basic indication, UFR, CRP, full blood count, serum electrolyte, creatinine, most of the complicated urinary tract infection end up with this complication. But even some of the patient need imaging, but not all the patient. Uncomplicated urinary tract infection, you don't need all these things, just to treat. So when you are collect a bit of urine culture, it's the best way to collect the urine sample for the culture is a midstream urine culture. Or maybe with the children, and if there are some urgent situation, we can choose the suprapubic one. Suprapubic one is the most sensitive one. When you are doing the suprapubic culture, so the yield should be less, even the colony count of 10 to the power of 3, it's significant. But the other sample, there should be more than 10 to the power of 5 for the single organism. So most of the other, when the patient is a bit of a uncomplicated urinary tract infection, so our setup, we do the urine analysis, full report, but the most of the Europes and they go by the urine dipstick. So the urine dipstick is a very sensitive waste, but routinely we are not using. But if the dipsticks are very valuable to assess all these things, specific gravity, pH, proteins, leukocyte, nitrites, all these are very sensitive. So it's a patient with the, if you do the urinary tract infection, if you use the dipstick, so the leukocyte level, so we can assess by the leukocyte esterase. So that's a surrogate marker for your pyuria. Or when they are with the urine infection, usually they are nitrates, it oxidides the nitrites. So the nitrite level indicate the probably evidence of the sepsis. So together with the increased leukocyte esterase levels and the nitrites, is a strong predictor for your urinary tract infection. Even without symptom, when you are when there's a positive leukocyte esterase and the nitrates, no need to have uncomplicated urinary tract infection. Leukocyte esterase positive and the nitrates positive, no need to urine culture, you can straightly start antibiotic. But only the leukocyte is positive and the nitrates negative, then again probably you have to send the urine culture. So these various strips are available. And as I said, so we don't have any clinical care pathway to manage urinary tract infection. If it is there, it's a very simple, very effective, and we can reduce the cost. And whatever these clinical care pathway based on the empirical data. So if you follow, so can prevent the treatment failure and the prevention of the antibiotic resistance. So these slides are not that important, just try to. So whatever the empirical antibiotic depend on the last 6 months our antibiotic sensitivity pattern in your regional microbiology lab. And these slides are you have got from the NICE guideline and the NHS trust. And these are just to see whether what is the usefulness of the probability having the bit of a clinical care pathway. It's very easy when the patient comes in, the female patient, 16 and the 65 in age, see whether this patient is a pregnant, non-pregnant. So if it's a non-pregnant, if it is uncomplicated urinary tract infection, no urine dipstick, no urine culture, you just start the antibiotic. or if the patient is pregnant, or maybe the male patient, or maybe catheter related, then before antibiotic, we have to send the urine culture. And see before, if it is a bit of uncomplicated urine tract, just you have to check your checklist. Say whether the bit of evidence of any vaginal discharge, or maybe history of any any bit of STD, any urethritis, any evidence of any atopic vaginitis. So if it is not there, again, you have to think twice. If it is not there, it's more favorable, uncomplicated urethritis. So this type of the emergency department, this type of a checklist is available. So what you have to see, all these things. So we will not miss anything. So when you develop our probably maybe the urinary infection, clinical care pathway, so we can consider this type of a thing. It's a very effective. So once you diagnose urinary tract infection, so it's very easy, it's uncomplicated urinary tract infection. You treat with a very bit of a in the nice guideline recommend to start with a nitrofurantoin, or maybe they giving trimethoprim. So that the recommended dose is, if you are giving the bit of a nitrofurantoin, just a 50 milligram, 6 hourly for probably 3 days. But in our guideline, it's recommended to give the 5 days. So these are our guidelines. So if it's uncomplicated urinary tract infection, we give the nitrofurantoin for 5 days, or if they are not tolerated, we can go for the epilexin. If the complicated cystitis again, so give the nitrofurantoin 50 milligrams, 6 hourly for probably 1 week. Or else you can give the norfloxacin, or maybe cefuroxime, or maybe coflavanox. So like all the guidelines available, which antibiotic to start. So this is probably just a brief introduction to the urinary tract infection. My topic is not to discuss the urinary tract infection, just to discuss the pitfalls. Lot of when they are treated, what happened? So they get the recurrent urinary tract infection. The definition of the recurrent urinary tract infection is when they get the bit of a urinary tract infection, more than 2 attacks per 6 months, or more than 3 attacks per year. So if they get the recurrent urinary tract infection, it's a big problem. So most things is when they get the recurrent urinary tract infection, better somehow maybe some way we can prevent the recurrent urinary tract infection, getting the adequate fluid intake, prevention the dehydration, maybe prevention of the constipation, avoid unnecessary catheterization, and the proper perineal hygiene, and in the diabetic, very good control of the blood sugar, and the post-coital voiding, frequent micturition, and the avoid latex contamination condom, and the maybe spermicide. And some of the time we can use some of the these temporary use, D-mannose, and the prebiotic. So there are various temporary guys, they are done even in the ESA guideline and the NICE guideline, they recommend there may be level 1 evidence, but by giving temporary use, D-mannose, and the prebiotic, we can reduce the incidence of recurrent urinary tract infection. And any ways to prevent the urinary tract infection by giving vaccination? This is a vaccination available, ME140. This is a vaccine available in most of the European countries. It's a 26 countries is available. It's contained a bit of inactivated E. coli, Klebsiella, Enterococcus, and the Proteus in the bit of a glycerol and the bit of sodium chloride. It's an oral vaccine. So we have to give it a 2 puff daily for 3 months. If you given that, so we can prevent the recurrent UTI for the 9 months. So there's a UTI free time for the more than 9 months. So that's now coming to the pitfalls. So we'll probably maybe like an interactive session. So this is 73-year-old lady presented with OPD with history of chronic backache for 2 years. no fever, no dysuria, but complain some stress, incontinence, and constipation. Past history is unremarkable except the UTI 1 year ago. Examination, no suprapubic tenderness, no loin pain. UFR shows the 10 to 12 pus cells. And urine culture positive for E. coli. And the antibiotic sensitive pattern revealed resistant to the most of the antibiotic except the meropenem, suggesting like a ES will produce in E. coli. So what is the correct treatment? What do you think? She's 73-year-old lady, present with the backache, not much of the urinary symptoms, but UFR positive for pus cells. They have a pyuria and the culture positive. And it's a culture positive, not only culture positive, it's like a ESBL pattern. So what is the correct treatment? Whether we are treating the nitrofurantoin or nitrofurantoin augmentin, meropenem. What do you think? So that's it's a very common thing. What the first pitfall when you are managing the urosepsis is a lot of patients, what happened, they come in the pyuria, not only the pyuria, they present with the culture positivity. So that's a first pitfall in the like asymptomatic bacteria. This patient is completely asymptomatic and the normal inflammatory markers. So it's in the most of the adult population with the asymptomatic bacteria doesn't need any treatment except in the pregnancy. And if you prepare the patient for an invasive genital procedure only, they need treatment. So the 5% of the sexually active female positive for this asymptomatic bacteria, and the prevalence increase with the advanced age. So it's very common practice. A lot of patient, elderly patient, they get the weak, maybe chest pain, sometimes maybe bit of urinary incontinence. The patient probably maybe herself or himself, they get it done the UFR. When there are a lot of pus cells, they go to the GP. When look it and there are a lot of pus cells, they request the urine culture. When the urine culture positive, with the pyuria and the positive urine culture, they come to the OPD. OPD just admit this patient for the evaluation. So it's a very common frequent admission in our ward. That's asymptomatic bacteria. If you treat this type of patient, they get more harm than the benefit. So most of the time, so the over treatment of the asymptomatic bacteria which result in the antibiotic resistance. So usually for the asymptomatic bacteria to diagnose you need the 2 consecutive urine sample. So the pyuria and we have to demonstrate the positive bulge culture. But in the men, asymptomatic bacteria is not that common. Even the single blood culture, the asymptomatic pyuria and the blood culture is enough to diagnose pyuria. But in the certain situation, I told asymptomatic bacteria has to be treated once it's a pregnancy, otherwise end up with the maternal and the fetal complication in the pregnancy. Asymptomatic bacteria has to be treated. But if you are preparing the patient for invasive genital procedure, you have to treat. But simple maybe catheterization, simple maybe routine cystoscopy doesn't need any antibiotic treatment. So this is a case 2. It's a very common thing again. It's a 65-year-old lady, diabetic for 15 years, currently on insulin, but with poor compliance, and her blood sugar is very poorly controlled. Examination, a significant probably left renal angle, she's febrile, but it's not like a bit of sepsis, and a lot of red cells, UFR, white cell count, everything is suggesting the patient has a true urinary tract infection. So what happened when you are treated with a bit of a augmentin? She was given 5 days of the IV augmentin followed by another 1 week of the oral augmentin. After 2 weeks, she was reassessed in the outpatient clinic. She was afebrile, no low tenderness, no suprapubic tenderness, but see the UFR, there are significant. Initially like a 50, now it's a more than 100, 200 pus cells. But white cell count is quite normal, CRP, everything normal, but only thing is HbA1c is 9. That means her blood sugar is very poorly controlled. How do you treat this patient? It's a very common thing. When you start treatment with especially when the blood sugar is very poorly controlled, so when you start with the pyelonephritis, you will not see the normal UFR. Sometimes maybe when the blood sugar is poorly controlled, initially maybe the patient, the pus cells may be probably the 25 to 30. But when you is the blood sugar not controlled, when re-evaluated, there may be frank pyuria. So the urine culture also negative. So the next problem we encounter in the clinical practice is this type of a sterile pyuria. Sterile pyuria. So first case is very clear, this is our patient. So there's a persistent pus cells without increase in inflammatory markers and the negative urine culture. First, when you think in the, our case is more the poor glycemic control associated with the papillary necrosis. So when you get the blood urine culture is a gold standard treatment to diagnose UTI, but some of the time what happened? Our urine culture is negative. So the first incident is a renal papillary necrosis. So in a lot of our elderly patients, they abuse a bit of analgesics. So most of the patients like analgesic induced or maybe chronic interstitial nephritis, they can have persistent pyuria and your pus cells are, probably your urine culture is negative. And in the United States, the 25% of the sterile pyuria are really due to sexually transmitted disease. So they're very important when the patient, your urine culture is negative. So the revisit and get the educated history, especially in the young patient, if the urine culture is negative, say that may be the case of probably the sexually transmitted disease. If you don't miss, it will end up with the chronic sequelae, maybe the urethritis, urethral strictures, when probably the maybe chronic salpingitis, maybe in future, ectopic pregnancy and all the sort of a complication. And in our setup with the patient, in the probably the urine culture is negative, always think about the renal TB. When your urine culture is negative and if there's a lot of constitutional symptoms, you have to think of the possibility of the renal TB. The renal papillary necrosis is a very common, important topic, but it is again under-evaluated. Some of the patient may be spectrum of some of the patient may be like our patient, completely symptomatic, and some of the patient may be end up with the severe renal colic, sometimes maybe like acute renal failure. They present with sometimes fever, sometimes maybe acute, probably maybe urinary tract obstruction and the acute renal failure. Sometimes to diagnose, we need the CT scan, maybe IVU. So as I said earlier, young patient person with the sterile pyuria, always think of the STD. So in our setup again, it's under-evaluated PID and the urethral stricture. So it's better to have this clinical care pathway, the UTI, very easy in the busy setup, even the non-medical, in the nurses. So with the maybe the checklist, we can see all this thing. The most of the busy setup, we miss all the getting the history and all. So this patient, 53-year-old lady, admitted to the medical with the low abdominal pain, dysuria, increased picturation for the last 3 days. She was febrile, blood pressure is normal with suprapubic tenderness, significant pyuria. There's a leukocytosis, CRP was elevated, and after urine culture, bit of a cotrimazole to give it for 48 hours. And she was discharged in the hospital, and the next day she readmitted following urine culture. That's also a common thing. So we diagnosed a bit of an uncomplicated bit of a urinary tract infection. And so probably maybe with the urine culture, that's again E. coli. It's like a ESBL pattern. So what to do? How do you manage this patient? Whether you are changing to the IV, we are changing to the meropenem, or giving the bit of bolus of gentamicin, or leave it alone. What do you think? Because sometimes in vitro and the in vivo, probably, the patient can be the completely now patient is asymptomatic with our current treatment, patient is completely respond. So probably it's because if you see whether the most of the asymptomatic bacteria, when you see the with your current treatment, the patient is well respond. So the bit of ESBL pattern not necessarily due to the pulmonary infection. So as you said, 5% of the normal population, they are having the asymptomatic bacteria. So probably it responds to the public antibiotics. So the culture positive to the asymptomatic bacteria, since the patient is completely asymptomatic, inflammatory marks are nicely coming down. So you can leave it alone. So again, the lesson is not to treat your report. So you just reassure the patient, you continue your same antibiotic. Then this is a 60-year-old patient, 3 days history of a high-grade fever with the chills and rigors, and the left side loin pain without dominin. On admission, she was very ill-looking, and see the very tachycardic, blood pressure 90/60 with significant left side tenderness. Suggestion? Suggestion of it's like a probably the pyelonephritis, it's a complicated pyelonephritis with all the features of the sepsis. If you see the news too, there maybe the score is more than 5. No, so that's this patient is a left pyelonephritis with the early sepsis. So how do you manage? I think one of the registrar, how do you manage this patient? Bhagya? So she is 60 years old, diabetic, fever, chills and rigors, left-sided loin pain, on admission ill-looking with tachycardic, low blood pressure, loin tenderness. No? Yeah, which antibiotic you are going to start? Yeah. Oh, meropenem, tazobactam, piperacillin. No, so see whether the patient is early shock. So give the fluid, send all the specimen for the blood culture, urine culture, and then start on the antibiotic. No, so preferably this patient is a more towards the severe sepsis. So the maybe by the tazobactam, piperacillin, no, meropenem. So if the patient is not improving, you can add bit of amikacin or gentamicin to. So same patient, what happened? So then patient, we are initial with your treatment, diabetic patient, 60 years, high-grade fever, chills, and all these suggestions the pyelonephritis and the heart rate, blood pressure, no? And there's some low tenderness. And again, you are after maybe basic investigation, UFR, urine culture, CRP, empirical antibiotic IV augmentin. Then after 48 hours, when evaluated patient, he had the persistent tachycardia, fever, significant loin pain. How do you manage this patient? So the basic concept with the urinary infection is once you start with the antibiotic, there should be dramatic improvement within 48 hours. So that's it with the rule of thumb. If the patient is not improved within 48 hours, so what to do? What to do? What are the possibilities? Yeah, show that. Oh, yeah, before that, no, the patient could be antibiotic. This is so the third pitfall really. So the emergence of the antibiotic resistance, but particular instant, what happened? So that after 48 hours, there's no good improvements. There's a persistent fever, tachycardia, and the bit of a version of the left loin tenderness. So that's to see whether you review your diagnosis or whether the patient has already there may be a complication. No, so that's why the most of the patient once again acute pyelonephritis. So maybe the treatment delay, there maybe end up with the perinephric or renal abscesses. Oh, like that, all the probably the things are first we have to exclude to see whether any perinephric or renal abscesses, any obstructive features. So probably may need with all this to rule out, maybe need the imaging. So if you have ruled out all this in the obstruction, maybe by the right. So then we have to think of the possibility of a antibiotic resistant. So you can trace the urine culture, and probably better this type of patient is the most probably it will end up with the EBS, the true ESBL producing urinary tract infection, pyelonephritis, probably again change into the carbapenicillin. Another example, 65-year-old lady, diabetic, again, coming with the fever with the chills and rigors for 3 days. She's hemodynamically stable, not much tachycardic with the loin tenderness. significant pyuria, CRP quite elevated with the leukocytosis. After urine culture, augmented started 2 days and the urine culture became positive for ESBL. Then, how do you manage this patient? Say with the, again, I had the same lesson. So, say simple, this thing, the rule of thumb is when you start with antibiotic, there should be improvement within 48 hours. If the patient improved within the 48 hours, I think probably no need to change. But if the patient after 48 hours, if the patient is not improving, we have to take it that seriously. For the urine culture is now positive for ESBL. Within 48 hours, if the patient is not improved, so probably you have to start it again, probably the carbapenicillin. This case to highlight the now the other emerging problems are not the patient with the ESBL producing, and we do come across there a lot of patients with the multi-drug resistant, even the carbapenicillin resistant E. coli. Now the emerging problem is a few cases they are carbapenicillin resistant E. coli. There's a 70-year-old male present with the background is a BPH on individual catheter. She's a diabetic CKD stage 5 hypertension, previous history of bladder carcinoma, surgery done, and admitted with the 2-day history of a fever, low abdominal pain, on exhibition with low blood pressure, tachycardia, left renal angle tenderness. The UFR taken with the catheter, field full pus cells, leukocytosis, and patient was started with all this bad history. We start with the meropenem after urine culture. And after 48 hours, patient is ongoing fever, CRP, white cell count, all the bit of elevated. How do you manage this patient? Complicated, where this diabetic, previous history of a recurrent indolent catheter. Now coming in the evidence of the pyelonephritis with the sepsis. And after bit of a meropenem 48 hours, still patient is symptomatic. How do you manage? Diabetic patient. Again, same thing, to see whether by the time, see whether the old any obstruction, any renal abscesses, perirenal abscesses, if that's there. And say that most of the time, this case sometimes may be like this patient giving meropenem, no obstruction, no perirenal abscess, no renal abscesses, and patient is continue to have a fever, most probably it's a carbapenicillin resistant E. coli. Or maybe all the things, but all things are possible. Diabetic patient, it may be a bit of emphysematous cholecystitis, maybe a bit of complicated renal abscess, or maybe perirenal abscess. Right? We have to think of all the things, and have been excluded, think of possibility of a carbapenicillin resistant E. coli. So only option. So our setup here, we have started with the colistin for this patient. This case, 75-year-old patient, known to have benign prostate hyperplasia, indwelling catheter for more than 6 months, present with the cloudy urine in the urine bag and the catheter. On evaluation, he didn't have any fever, completely asymptomatic, no suprapubic tenderness. Catheter was changed in the emergency department, and some other reason someone changed the catheter tip for the, and it yielded a bit of a candida. How do you manage this patient? Praveen, how do you manage this patient? So the catheter was, patient is completely asymptomatic, no, the catheter tip contained probably the candida. So it's a common thing. So when there's a candida, it's said probably in the catheter, no indication to say, even in the just after catheter, when the catheter, it can be, but in the female, it can be a contaminant, or maybe it's maybe candida, maybe colonized. What we are is not the contamination colonized, what we are in the true infection. Here, patient is completely asymptomatic, so you can leave it. So if you have with a symptomatic, if the suppose now patient is symptomatic, then probably, so you have to send them from the new catheter, the catheter removed, you can do the midstream urine, or if the catheter is still there, on the new catheter, we can send the, for the urine for the culture and the repeatedly it is positive and the patient symptomatic, then probably they have to think. Otherwise, we can leave it alone. So again, same, like a same on the individual in catheter for a BPH for the 6 months. Present with the high-grade fever, right low in tenderness. Examination, she was hemodynamically stable, but see a lot of pus cells, inflammatory markers are white cell very high. So it is not an unusual case. Every day, probably with the casualty ward come in this type of patient on the catheter related, probably the severe pyelonephritis. So again, with the patient, all the features of the maybe if you're the news to patient, maybe a lot of sad. So how do you manage this patient? How do you manage this patient? So this patient, probably the catheter related, probably the severe pyelonephritis, so after seeing the urine culture. So the patient is not early, the new score is high, better again, better with the tazobactam, piperacillin, and if the renal function normal, you can top up with the probably your gentamicin or amikacin. This is the last slide probably. So a lot of patient will get the UTI, a lot of patient end up with the recurrent UTI. Lot of patient in the diabetic, lot of patient in the cardiac comorbidities. Now we are in the SGL2 inhibitors. Whether when the patient getting the with a recurrent UTI, whether we are discontinuing or whether we are continuing. What do you think? What do you think? Evidence is if the patient in recurrent UTI, there's no close correlation with the SGL2 inhibitor and the UTI. The recommendation is if the patient is still probably had the diabetic and other thing, maybe the patient had the maybe like a melanocytitis or maybe between this thing temporarily you can discontinue, but the long term the evidence is you have to continue SGL2 inhibitor, not to discontinue. So benefit continue the benefit the SGL2 is more probably the beneficial than the harm. So that's all. So if there are any queries, I think for the audience, there are a lot of maybe the expert panel is there. So with their help, we can answer.